Carbon monoxide exerts its toxic effects by binding to circulating hemoglobin and thereby reducing the oxygen carrying capacity of the blood. Hemoglobin absorbs carbon monoxide 200 times more rapidly than oxygen. So it's not allowing oxygen to bind to hemoglobin and it can cause hypoxic effect. Some of the clinical manifestations include headache, muscular weakness, palpitation, dizziness, confusion, which can progress towards coma. The skin will be turning blue and the first reading of pulse oximetry. So in the management, our goal is to reverse cerebral and myocardial hypoxia. The first thing you want to do is to carry the patient to fresh air immediately, open all the doors and the windows, as this will allow oxygen to enter the system and it can displace carbon monoxide. You want to loosen all tight clothing, initiate CPR if required, administer 100% oxygen. You want to prevent chilling, wrap the patient in blanket. Do not give alcohol in any form or permit the patient to smoke. Smoking will cause vasoconstriction of the blood vessels and to worsen their hypoxia. Skin contamination injuries from exposure to chemicals are challenging because of the large number of possible offending agents with diverse actions and metabolic effects. The severity of a chemical burn is determined by the mechanism of action, the penetrating strength and concentration, and the amount of and duration of exposure of the skin to the chemical. The management, you want to prevent the skin from exposure. You wash the skin thoroughly with water. And then one thing we should take notice is that we don't want to water should not be applied to burns from lye or white phosphorus because of the potential for an explosion or for deepening of the burn. Lye is sodium hydroxide. So we're going to talk about organophosphate poisoning. They are a diverse group of chemicals used in both domestic and industrial settings. They can be found in insecticides, pesticides, and some nerve agents. The pathophysiology behind this is that when organophosphate enters the body, they bind to acetylcholinesterase. Acetylcholinesterase is to break down acetylcholine.
Acetylcholinesterase.
Acetylcholinesterase. Acetylcholinesterase is an enzyme that degrades the neurotransmitter acetylcholine. Acetylcholine is a neurotransmitter that stimulates our cholinergic receptors and our nicotinic receptors. And acetylcholinesterase is to break down acetylcholine to reduce the action of it. Some of the actions of acetylcholine include their receptors are found in the eye, so they cause constriction of the pupils. In the heart, they decrease the heart rate. In the GI, they cause
Doesn't
peristalsis.
increase heart rate, decrease heart
Decrease
rate.
it. They decrease heart rate. In the GI, they cause peristalsis. In the bladder, they help with urination. So when acetylcholine finishes its work, acetylcholinesterase helps to break down this and so that we just go about our normal day. But when organophosphate is in the system, they inhibit acetylcholinesterase. So acetylcholine is now prolonged and there's now overstimulation of acetylcholine in the body. The clinical manifestations can be divided into three: muscarinic effect, nicotinic effect, and CNS effect. This mnemonic can be used to remember the signs of muscarinic effect of organophosphate. Sludge. So there is salivation, there is lacrimation, urination, diarrhea, GI upset, and emesis. So when you see if somebody is poisoned with organophosphate, these are some of the symptoms that they present with. When you see somebody salivating, there's lacrimation, there's urination, you should already be suspecting organophosphate poisoning. Dumbbells is also another mnemonic that we can use. The nicotinic signs and symptoms include muscle fasciculations, cramping, weakness, diaphragmatic failure, autonomic nicotinic effects which include hypertension, tachycardia, mydriasis, and pallor. The CNS effects include anxiety, restlessness, confusion, ataxia, tremors, seizures, and coma. Thank you.
for the treatment of poison, for the treatment of poison. So, in our process of poisoning,
I'm not getting you.
to continue treatment of poisoning, in our process of poisoning, you need to maintain the airway and the airway control and adequate oxygenation because when a person poisoning, what it does is that it depresses the muscle activity, it causes paralysis. So adequate monitoring of the oxygenation because is needed for management of unrelated poisoning. So also if patient presents late, you can intubate the patient, which is necessary in case of respiratory distress such as bronchospasm, bronchospasm, bronchoria or seizures. Or if we are able to pick up this poison early, we can administer atropine, which is an aggressive method for treating bronchiolic poison. Also, using choline should be avoided in this poison because using choline will also cause prolonged paralysis of the muscles. Okay, so now for the medications, there are three medications we use. We use atropine, palidoxime, and diazepam, which is benzodiazepine. So for atropine does what atropine does is that it reverses the cholinergic activity of olfactory poisoning. So, like you said, olfactory poisoning binds to acetylcholinesterase, which prevents the activity of acetylcholinesterase, which causes the degradation of acetylcholine in the muscle. So, when acetylcholine remains in the muscle junction, it causes prolonged stimulation of the receptors in the muscle, it causes fasciculations, contractions, and can also cause muscle weakness. So, atropine will reverse this activity and also bind to acetylcholine to prevent the action of acetylcholine on the receptors. So, they administer atropine, which is an anticholinergic agent, to counteract the muscarinic effect of manifesting poison. The initial dose is 1 to 3 milligram IV inhaled, which is repeated every 5 to 15 minutes. But distribution of dry and adequate ventilation is achieved. So high dosage may be required in severe cases. So second one is palidoxime, which is administered because palidoxime, also known as 2-PAM, what it does is that it helps to reverse the binding of polyphenols poison and acetylcholinesterase. So polyphenols poison does is that binding to acetylcholinesterase and reducing the activity. So that doesn't mean we reverse that binding, we inhibit the binding of OP to acetylcholinesterase of acetylcholinesterase. So that's what it does. So the administer pyridoxine initial dose is 1 to 2 gram IV in adults, which is given over 30 minutes. And this dose is repeated every 12 hours, which when is indicated in different conditions, such as if there is repeated to prevent or if symptoms seem to get worse over the day, or if patient is exposed to the poison, we administer pyridoxine every 12 hours. So for benzodiazepines, which is example is diazepam, which is used in poison treatment. And that one helps to control seizures.
Please slow down. You are moving too fast. What's the problem?
And diazepam, which is used in opioid treatment, helps to control seizures and reduce agitation. So diazepam is is one of the medications used. So we give 5 to 10 milligram IV in adults and repeated as needed. We should note that all these medications have a side effect. So for atropine, atropine can also cause tachycardia, which is contraindicated in it should not be used. Also, pyridoxine atropine can also cause dry mouth and flush skins and tachycardia, which should not be used. Also can also cause constipation. Yes, atropine can cause constipation because it affects the GI system. So also palidoxime can cause headache, nausea and vomiting, and also dizziness or feeling of confusion. Benzodiazepine can cause serious depression and also in some cases can also lead to drug addiction.
So I'll be taking the admission and discharge criteria for management of poison patients. So the admission criteria is you admit patients with severe poisoning. So if there's severe poisoning, you must admit the patient. Yes. And if there are ongoing symptoms, if the symptoms are still like present in the patient, you also admit the patient. Yeah. So and patients requiring intensive monitoring and treatment. These are patients that have
that are severely poisoned and have ongoing symptoms. So they are the ones that require intensive monitoring and treatment. So the discharge criteria: discharge patients who are asymptomatic after an appropriate observation period and have normal laboratory results. So once they don't show symptoms of poisoning again, you can discharge them. And once you check their laboratory, once you do laboratory tests for these patients and it's normal, you can discharge the patients. Prevention and education, counseling. You can educate patients and families on the safe storage and use of medications and chemicals. So you can educate the patients and families to store these to store their drugs, their chemicals, and anything that can cause poisoning safely, like to keep them away from children or to label them correctly to prevent misuse of these substances, and also use of medication. And also they should use like educate them on the use of their medications and chemicals, like their drugs, paracetamol, everything. You educate them on the way they should use it, and chemicals too, like insecticides. They spray it, they should leave the room for a few minutes, pesticides and all. So poison control centers, encourage immediate contact with poison control centers for advice on managing potential poisons. So if they need immediate if they need treatment, immediate treatment for this poisoning, like they should contact poison control centers that are nearby so that it will not prolong the symptoms of the poison, which can eventually lead to death.
Okay, now I guess we come to the end of it. So, conclusion: effective management of a poison patient require fast and rapid evaluation and stabilization of the patient. And also, for identifying the toxins, we have to identify the toxins through history taking, examination, diagnosis tests, guys, specific for the treatment, yeah, because you have different causes and different types. So decontamination methods and antidotes, when applicable, are crucial, complemented by ongoing monitoring and supportive care. Rapid and appropriate intervention is key to improving prognosis and outcomes. Thank you very much for your attention.